we're going to change focus now a little bit and go to the liver, that most mysterious of organs, which the ancients used to read and predict the future on, and portend the coming events. And there is no better doctor in this city to discuss liver disease and the patient with cholestatic liver disease than Dr. David Sass, who is professor of medicine and medical director of liver transplant at the Sidney Kimmel Medical College of Medicine. What you may not know is that he's been in demand throughout the city to give lectures. In fact, so much so that Jefferson, Sidney Kimmel, provided him with a chauffeur. And he was driven around the city for quite some time by this same chauffeur. And one day the chauffeur turned to him and said, listen, Dr. Sass, I've heard your lecture so many times, I can give it myself. So Dr. Sass said, well, I'll tell you what, I'll put on your chauffeur's cap and sit in the audience, and you stand on stage and use my slides and give the talk on hepatitis. And he did. And at the end, the chauffeur got applause, and the floor was thrown open to questions. Someone asked a very complicated question initially on hepatitis and hepatitis B and C. And his chauffeur said, you know, that question is so easy, even my chauffeur in the audience can answer it. And he pointed to Dr. Sass, who took it from there. So I'll turn the program over to Dr. Sass. Fortunately, we have him today and not his chauffeur, and he will tell you about cholestatic liver disease. Dr. Sass.
Thank you, Dr. Lefton. I'm just trying to get my screen here. 1 second.
If you have trouble, ask your chauffeur.
Yeah, give me 1 second here. All righty. All right, I think everybody can see my screen now. So thank you very much for that kind introduction, Dr. Lefton. Thank you for both to you and Dr. Ortiz for kindly inviting me to give today's address. I am going to be discussing an approach to the patient with cholestatic liver disease. And I have been invited in previous years to speak at the County Medical Society, and most of the time I've been speaking about liver disorders such as viral hepatitis, fatty liver disease, cirrhosis, and liver transplant. But I figured this is a topic that's not often discussed, but one that's definitely worth bringing to the attention of the primary care physicians out there. And so I really wanted to delve into the topic of cholestatic liver disease. I do not have any conflicts of interest to disclose. So what I propose to discuss over the next 45 minutes are the following objectives. Firstly, I'm going to define what is meant by cholestasis. I'll then provide an algorithm for alkaline phosphatase elevation and give a differential diagnosis for intra and extrahepatic cholestasis. I'm going to speak for a bit of time on pruritus, as that's one of the cardinal manifestations of patients with cholestatic liver disease. We'll talk a little bit about pathophysiology and management. We'll also talk about other complications of cholestatic liver disease, including fat-soluble vitamin deficiencies, metabolic bone disease, hyperlipidemia, steatorrhea, and fatigue. And then at the end of the talk, I'm going to spend a bit of time discussing the two main primary liver disorders that produce cholestatic liver disease, which are primary biliary cholangitis, or PBC, and primary sclerosing cholangitis, also known as PSC. So I'm going to start with a brief case presentation, and it's a patient that may be somewhat familiar to most in the audience. A 56-year-old woman presents to a PCP for routine annual examination She was asymptomatic other than the symptom of mild fatigue and feeling run down for a few months. Her lab tests revealed an elevation in the alkaline phosphatase of 445 with otherwise fairly normal blood work. Her ultrasound abdomen showed a normal liver spleen size, normal liver morphology, a normal gallbladder, and a normal common bile duct. Her only medication was Synthroid for hypothyroidism, and she was not on any over-the-counter medications. Her PCP ordered viral hepatitis serologies that were negative and then referred her on to see a hepatologist. So I'm going to come back to this presentation a little later on, but this is just to introduce the topic of an rather asymptomatic patient presenting with ALK phos elevation. So what is meant by the term cholestasis? Well, it really comes from the Greek chole, meaning bile, and the Greek word stasis, which means standing still. So essentially, it's an arrest in the flow of bile. And what you can see in this H&E liver biopsy slide is a liver biopsy showing significant hepatocellular and canalicular cholestasis, as evidenced by the orange pigment seen throughout the hepatocytes of the liver. Now, how does cholestasis occur? Well, essentially, it's an impairment of hepatobiliary excretion, and normal biliary constituents will appear in the circulation. The etiology for this cholestatic disorder may be found at the level of the hepatocyte, which is called tissue cholestasis, or it may be involving the small bile ducts or the large bile ducts of the liver. And the characteristic biochemical pattern is an elevation in alkaline phosphatase and GGTP, and the patients may or may not have jaundice. It can be an acute self-limited condition, or it may be chronic with irreversible duct loss and progressive biliary fibrosis. So, when you're assessing a patient with abnormal liver enzymes, there are essentially two main liver enzyme patterns. There is a hepatocellular or necroinflammatory pattern, where you see a predominant AST-ALT elevation more than 5 times the upper limit of normal, and very minor alkaline phosphatase elevations. What I'm going to be discussing today is the cholestatic pattern, where you have a predominant alkaline phosphatase elevation, usually at least 3 to 5 times the upper limit of normal. There may be some mild AST-ALT elevations. And like everything else in medicine, one could also see a mixed pattern where you get a combination of hepatocellular and cholestatic liver injury. Now, it's important to note that not all alkaline phosphatase elevation is from the liver. There are other sources of alkaline phosphatase, including the bone, the intestine, and the placenta. And the way one can differentiate these entities are twofold. One can either check liver alkaline alkaline phosphatase isoenzymes, which break up the alkaline phosphatase into various components, letting us know what percentage of the ALK phos is coming from liver versus bone, intestine, or placenta. Or one could check a GGTP, a gamma glutamyl transpeptidase. So those are the two ways to differentiate liver-related ALK phos elevation from other ALK phos disorders. So this is now showing you a basic algorithm for how we approach patients with an elevation in alkaline phosphatase. The first is to rule out physiologic causes. As I've already mentioned, there is a placental component of ALK phos, so the patient may be pregnant, which may explain the ALK phos elevation. It may also be elevated in a postprandial state, and this could be increased up to 1.5 to 2 times normal. And so alkaline phosphatase may be from the intestine. But more often than not, the ALK phos is from one of two sources, either the bone or the liver. And again, you can differentiate these two by checking the GGT or ALK phos isoenzymes. If the GGT is normal, the ALK phos is likely of bone origin, and one may want to do further tests to rule out a disorder such as Paget's disease. On the other hand, if one sees GGT elevation, It's often of hepatobiliary origin. And the next test to order would be a right upper quadrant ultrasound. So the purpose of doing a right upper quadrant ultrasound in a patient with alkaline phosphatase elevation is to be able to differentiate intrahepatic from extrahepatic cholestasis. So you want to see if there's any biliary ductal dilation. In other words, is the disorder involving the intrahepatic bile ducts or the larger extrahepatic bile ducts, such as the common bile duct? So moving on with our algorithm, if the patient is found to have dilated bile ducts on the ultrasound, that would indicate that they have extrahepatic cholestasis. And the next test one would want to order would be an MRI, MRCP, an ERCP, or a CAT scan to evaluate for disorders that may produce biliary ductal dilation. If they have non-dilated bile ducts, we're then dealing with the entity called intrahepatic cholestasis. And one of the most frequent disorders we see there is PBC, which we'll talk a lot more about later. And the hallmark serologic test to diagnose PBC is the antimitochondrial antibody. So one could next check an AMA, and if positive, you basically have your diagnosis of PBC. If negative, one may then have to consider other disorders. We'll talk about what those may be. And those may involve doing a test such as an MRCP or a liver biopsy. So this slide shows you the differential diagnosis for intra and extrahepatic cholestatic disorders. In the extrahepatic group, we have benign conditions such as choledocholithiasis, extrahepatic biliary strictures such as ischemic strictures, iatrogenic strictures, or a disease like HIV cholangiopathy. They may have PSC involving the extrahepatic bile ducts, and that's another benign disorder. They may have a parasitic infection such as Ascaris burrowing into the common bile duct, and that can cause extrahepatic cholestasis. And then the malignant disorders more commonly would be cancer of the head of the pancreas, or even malignant lymph nodes in the porta hepatis may cause an extrahepatic obstruction. As far as the intrahepatic disorders are concerned, the two cardinal disorders would be PBC and PSC. And again, we'll talk a lot more about those. Drug-induced liver injury, TPN, infiltrative liver disorders such as sarcoid amyloid lymphoma, and particularly in the ICU patient population, you should always remember certain diseases that can cause cholestasis. Sepsis being the most common, congestive hepatopathy such as right heart failure being another, drug-induced or TPN again can affect the ICU population. And then there are some disorders that are very specific to different patient populations, such as cholestasis of pregnancy, graft versus host disease in patients, for example, who've had bone marrow transplant, chronic allograft rejection in patients who've had liver transplantation. There's another disorder called idiopathic adulthood ductopenia, which is the adult form of Alagille syndrome. These are all disorders that can cause intrahepatic cholestasis. So now that we have a basic framework for the types of diseases that can cause cholestatic liver problems, what I want to do over the next few minutes is discuss the disease manifestations. And the main ones being pruritus, fat-soluble vitamin deficiencies, metabolic bone disease. You've already heard a lot about that today in Dr. DiMarino's celiac talk, where these patients may be prone to developing osteoporosis, and so too for patients with cholestatic liver disease. And then there are miscellaneous disorders, including, miscellaneous complications such as hyperlipidemia, fatigue, and steatorrhea, which can also be seen in patients who have cholestatic liver disease. So as I talk about these various complications, much of what I'm going to be referring to today can be found in these two very important reference documents. One is the EASL Clinical Practice Guidelines for the Management of Cholestatic Liver Disease, published in 2009. And the other is the ASLD Guidance Document for Managing PBC, which was published in 2018 in Hepatology. So let's talk about cholestatic pruritus first. This is a very common symptom, probably one of the commonest symptoms one sees in cholestatic liver disease. It may be mild and tolerable, but frequently can be very debilitating. It can dramatically affect one's quality of life. It can cause sleep deprivation, depression, and induces suicidal ideations. There does tend to be a diurnal variation of intensity in the majority of patients, and it's most intense late in the evening or early at night. The location of the symptoms typically involves the limbs, the palms, the soles, although it may be a generalized disorder. And patients may develop secondary excoriations from significant scratching, and they can develop a disorder called prurigo nodularis, where they develop skin lesions related to intense itching and scratching on their skin on a continual basis. Now, studying itch in cholestasis may be difficult because obviously it's a very subjective symptom. So itch intensity is mostly evaluated by visual analog scales or the 5D pruritus scale. There have been devices to objectify scratching activity to evaluate itch intensity in order to prove efficacy of novel therapies. But these devices have limited availability and they are costly and they are no longer the gold standard. So nowadays, visual analog scales and quality of life questionnaires tend to be the way in which we really objectify the degree of itching. In terms of cholestatic experimental animals, unfortunately, the animals that have been subjected to experiments barely develop itch. And so unfortunately, there's really no proper rodent model of cholestasis. What I'm showing you on this slide is just some of these instruments used to quantify degree of itch. So you can see on the left side, 2 different visual analog scales in terms of having 0 itch, which would be scored as a 0 versus the worst imaginable itch, which is a 10. And also the visual analog scale for sleep disturbance, no sleep loss versus I cannot sleep at all. The one below that just gives you a happy face with no itch and obviously a sad face for maximal itch. And the patient's asked to put a line on the scale as to what the intensity of itching is. And the scale that's more commonly used in research trials is the 5D pruritus scale. And the 5D stand for duration, how long has the itch been present, the degree of itching, the direction in terms of whether it's getting better or worse, the disability that it's causing in terms of sleep deprivation and affecting one's leisure, social activities, housework, etc. And then the distribution of the itch. What part of the body is it predominantly affecting? So those are the 5 Ds on the scale. Now, I am going to talk about ways in which we manage itching. But in order to do that, I think it's important to have some basic understanding as to the pruritogens or the mechanism of cholestatic pruritus. So there have been recent findings that indicate lysophosphatidic acid as a potent neuronal activator and autotaxin, the enzyme which forms lysophosphatidic acid and may form a key element for the long-sought pruritogenic signaling cascade. There are a number of clinical observations which indicate that these potential pruritogens, number one, accumulate in the systemic circulation. And this is as indicated by the relief of severe pruritus after treatment with plasmapheresis as well as albumin dialysis. These pruritogens are also secreted into the bile, as proven by the rapid relief of severe pruritus with nasobiliary drainage or following treatment with the bile acid sequestrant cholestyramine. These pruritogens are biotransformed in the liver and or gut, as indicated by effective treatment such as the pregnane X receptor agonist rifampin. And finally, they affect endogenous opioidergic and serotonergic systems, as shown by alleviation of itching by both naltrexone and sertraline. So there's recent evidence showing that LPA formed by autotaxin represents this long-sought trigger of the unmyelinated itch neuron endings. And there's a biliary factor X, which might stimulate autotaxin formation, which remains to be unraveled. So these are sort of current theories as to how itching may occur in patients with cholestatic liver disease. But based on this sort of pathophysiologic pathway, these are the 4 lines of treatment that we adopt to manage patients with itching, which can be very disease altering, should I say, very life altering. This particular slide comes from the EASL practice guidelines, showing the different stepwise fashion in which we manage pruritus. So the first line treatment is cholestyramine or Questran, which is a bile acid sequestrant. It's an anion exchange resin. And that's actually the first line treatment for patients with cholestatic liver disease who have a lot of itching. The problem is the dosing can be rather difficult to ascertain, and it can cause symptoms in the way of bloating, constipation, diarrhea, or nausea. If patients don't respond to cholestyramine, and I'll usually go up to a maximal dose of 8 grams BID, 16 grams a day, the next line of therapy is rifampin. Now, rifampin, as you're all aware, is an anti-tuberculous drug. It's a drug that is a PXR agonist. And as I mentioned, the pregnant X receptor is in the pathophysiologic pathway of pruritogens. And so we can use this drug, rifampin. Usually I'll start at a dose of 150 milligrams a day, and one can dose escalate to up to 600 milligrams a day. But as you're probably aware, there is a risk of hepatotoxicity with this drug, and 10% may develop a hepatitis, usually occurring within the first 2 months of treatment. And so one does have to monitor LFTs while they're on the drug. The third line would be the opioid antagonist naltrexone, starting at a dose of 12.5 milligrams per day, dose escalating to up to 50 a day. And there may be some side effects with that drug. And then the fourth line drug is sertraline or Zoloft, starting at 25 milligrams a day, up to about 100 milligrams a day maximal dose. So these are the different drug regimens that one may consider to manage pruritus. There have been some unproven experimental therapies, and there was some anecdotal use of gabapentin and cimetidine, didn't prove to be very effective. There's lack of or limited efficacy and excessive side effect profiles of antihistamines and phenobarbital. So I rarely will use antihistamines to manage patients with pruritus from cholestatic liver disease. There is some experimental evidence that extracorporeal albumin dialysis, plasmapheresis, or phototherapy may be of benefit. But very often for patients with cholestatic liver disease, transplantation may still be the best solution. But if patients don't have particularly high MELD scores, the access to transplant may be somewhat limited. So moving on to the next complication of fat-soluble vitamin deficiencies, it's important to know that patients with cholestatic liver disease may develop vitamin A, D, E, or K deficiency. I typically will check levels every 1 to 2 years, and if deficient, they will need to be repleted. For vitamin D deficiency, we'll often give a 50,000 unit capsule 1 to 2 times a week. For vitamin A deficiency, for symptomatic patients, we'll replete them with 100,000 units daily for 3 days, then 50,000 units daily for about 2 weeks. And then often we'll get them on a regimen of about 10,000 units 3 times a week as a maintenance. And I'll be continuing checking levels to make sure that their levels are appropriate. I would say vitamin D and vitamin A deficiencies are the most commonly seen. I wouldn't say I see vitamin E deficiency all that often. And then, of course, vitamin K deficiency may be present too with a prolonged INR. Next is the metabolic bone disease or osteoporosis disorders. The relative risk for osteoporosis in PBC patients compared to age and sex-matched healthy population is around 4.4. This is typically a low turnover osteoporosis in which bone formation is inhibited and bone resorption is low normal. Interestingly, vitamin D metabolism is often normal, except in those who develop jaundice or clinically advanced disease. And so one should be checking vitamin D levels at least annually. Often patients who develop metabolic bone disease are asymptomatic, and it's really diagnosed by doing a baseline DEXA. And if the DEXA is normal, I'll usually rescreen them every 2 to 3 years, just by virtue of having a cholestatic liver disease. The recommendation for those who develop osteopenia is exercise, daily calcium and vitamin D repletion in the at-risk population. But when patients develop true osteoporosis with a T-score less than 2.5 by DEXA, we will often prescribe bisphosphonate therapy such as alendronate, 70 milligrams a week. There has been randomized controlled trial to show that it significantly improves bone density when compared with placebo and the bisphosphonate etidronate. There is a relative contraindication that of GERD or significant varices, because bisphosphonate therapy can cause some esophagitis. So one has to be somewhat cautious in those patients. Hyperlipidemia is another manifestation of cholestatic liver disease. All chronic cholestatic diseases may be complicated by hyperlipidemia. It's found in about 85% of PBC patients. Xanthelasmas may occur and be somewhat troublesome. I'm showing you a picture of xanthelasmas in the bottom right of this screen. In PBC patients, the HDL cholesterol is typically elevated. Lipoprotein X may also accumulate, but there's no significant correlation with increased cardiovascular risk. UDCA, which is used to treat PBC, lowers LDL cholesterol, and that may be the initial step in therapy. But treatment is usually only offered based on individuals' risk factors for cardiovascular disease. Now, it's important to note that statins are safe in this patient population, even if they do have abnormal liver enzymes. And fibrates have been used safely in some as well. Steatorrhea can occur in patients with advanced primary biliary cholangitis. The etiology is thought to be due to decreased bile acid delivery with insufficient micellar concentration of bile acids in the small intestine. But they may have other coexisting conditions which can lead to steatorrhea, which can have a different treatment approach. If they have decreased intestinal bile acid concentration, one may have to substitute medium-chain triglycerides in the diet and decrease their total fat intake. If they have concomitant exocrine pancreatic insufficiency, one may need pancreatic replacement therapy. If they have coexistent celiac disease, which can be seen in conjunction with PBC, then a gluten-free diet may be indicated. And if they have SIBO, which is a condition that Dr. Parkman alluded to earlier, they may have coexistent scleroderma, and they may need intermittent broad-spectrum antibiotic therapy. So if they are having symptoms of steatorrhea, one may have to investigate further to rule out other concomitant disorders that can occur in patients, for example, who have PBC. And the last symptom to delve into is that of fatigue. And it can be a complex and rather debilitating symptom. The prevalence is somewhere in the order of 70 to 80% of patients with PBC, but it may also be seen in patients who have PSC or drug-induced cholestasis. The pathogenesis is really unknown. There's poor correlation between the degree of fatigue and the stage of cholestatic liver disease. But if you have a patient, for example, with advanced PBC who has fatigue, one should rule out other conditions that may be reversible, such as depression, anemia, hypothyroidism, adrenal insufficiency, renal dysfunction, and sleep disturbances. If patients are on beta blockers or calcium channel blockers, you may have to do dose modifications because that may be contributing to fatigue as well. There has been some evidence that modafinil, which is a drug used to treat narcolepsy, sleep apnea, and other shift work sleep disorders, may be of benefit to treat fatigue in this patient population, but it still needs further study. So the emphasis should be on stress reduction, healthy lifestyle, avoidance of alcohol and caffeine, regular exercise, and adequate sleep. And again, it can be a very vexing problem to treat in your patient with cholestatic liver disease. So the summary of this portion of the talk is that care of patients hinges on identifying the underlying etiology and treating reversible causes. The awareness of these complications of cholestasis and implementation of appropriate preventative and therapeutic strategies is essential, and PBC and PSC are the most common causes of chronic cholestasis. So what I'm going to move on to next is the two primary liver disorders that cause cholestasis, which are PBC and PSC. PBC stands for primary biliary cholangitis. Now, interesting, this disease used to be called primary biliary cirrhosis, which also has the abbreviation PBC. But about 4 or 5 years ago, the name was changed to be primary biliary cholangitis because the term primary biliary cirrhosis is really a misnomer because very few patients with PBC actually have histologic cirrhosis. Most patients have very early stage or mild disease with no evidence of cirrhosis. So in my comments on PBC, I will be referencing the practice guidelines, both from the ASLD, which was published in 2018, as well as the European Association for the Study of Liver, EASL, which was published in 2017. So how do we diagnose PBC? Well, there are essentially three main elements to the diagnosis. One has to have an unexplained elevation of alkaline phosphatase more than 1.5 times the upper limit of normal. One has to have a positive antimitochondrial antibody, which is the hallmark serologic test, and evidence of non-suppurative destructive cholangitis on histology. And you can see a liver biopsy alongside showing intense proliferative cholangitis with a lot of inflammation around the bile ducts. Now, in order to make a diagnosis, one needs two of these three elements. So you have to have the ALK phos elevation with a positive AMA, or the ALK phos elevation with a biopsy proof of PBC. Or, of course, you can have a biopsy with a positive AMA, but almost everybody will have an ALK phos as the initial test for screening. So you need two out of these three criteria to make a diagnosis. So factors leading to disease initiation in PBC are not well understood, but much like all other autoimmune conditions, there's likely a strong genetic predisposition with environmental influences leading to significant role in disease occurrence. And there's interaction with immunogenetic and epigenetic risk factors, and this leads to chronic immune-mediated biliary epithelial injury, cholestasis, ductopenia, and progressive biliary fibrosis. There are a number of lines of evidence supporting a genetic predisposition. There are some risk alleles that have been discovered with genome scanning. There's also data from monozygotic twins showing concordance in several monozygotic twin pairs around the world. So there are a number of lines of evidence supporting a genetic component. It's likely to be a complex polygenic disease, not a single gene defect. But there are also a number of environmental factors, such as a prior exposure to a bacterial infection or some sort of xenobiotic chemical that sort of, in patients with a genetic predisposition, can lead to initiation of the disease. There's then an immune response involving defective regulatory T cells, production of the antimitochondrial antibodies, and autoreactive CD4, CD8 T cells to pyruvate dehydrogenase complex E2. PDC-E2 is the main antigen to which the AMA is directed. So this immune response occurs, leading to bile duct damage, ductopenia, and progressive biliary fibrosis. Now, what is the clinical phenotype? Well, it involves women far more commonly than men. There's a 9-to-1 ratio of women to men. Most women are diagnosed over the age of 45 years. 95% of them have a positive AMA antibody, but there are two specific ANAs that may be positive too. One's called an SP100 and the other one is a GP210. These are specific ANAs that may be seen in patients with PBC. They may also have an elevated serum IgM marker in their blood, and their main symptoms are pruritus and fatigue, seen in about 50 to 70% of patients. Notably, jaundice is a very late manifestation of PBC. If you see a PBC patient who already has an elevated bilirubin and jaundice, that's usually an indicator that they need to be evaluated for liver transplant because their disease is very advanced by that point. If you did an MRI, MRCP on these individuals, the test will almost always be normal. You really shouldn't see any biliary ductal changes on MRCP imaging in a PBC patient. For those who undergo liver biopsy, one sees a lymphocytic infiltration with what's called a fluoroduct lesion, and I'll show you an example on the next slide. They may also have the presence of granulomas. They may also have associated autoimmune conditions. 35 to 55% will have autoimmune thyroid disease or Sicker syndrome. I'm showing you on the left side of the slide the fluoroduct lesion, which is the stage 1 PBC. This is early disease, and this is basically showing you a granulomatous destruction or inflammation around the bile ducts. On the right side, you see a patient who has very late disease where they have loss of bile ducts or ductopenia. Now, what is the role of liver biopsy in PBC patients? If they have a positive AMA, if they have an ALK-Phos that's more than 1.5 times normal and a low AST, then the positive predictive value for PBC is greater than 98% with an 80% sensitivity and a 92% specificity. So there's really no role for a liver biopsy in such an individual. So when do we do liver biopsies? Well, we can do it if they have a negative AMA and you want to confirm the diagnosis. If you want to rule out an overlap syndrome where they may have autoimmune hepatitis coexisting with PBC, or for premature ductopenic variants, and also to evaluate non-responders to URSO. That would be another indication for a biopsy. But we can stage disease with the absence of doing a biopsy by doing either a fibroscan, which is a transient elastography test done in the office. We can do ultrasound or MRI elastography to get a fibrosis staging, or one can calculate an APRI score, which is an AST to platelet ratio, which is a test that can be done through blood work. Now, what I'm showing you on this slide is the GLOBE score, which has been validated to predict outcomes of patients with PBC receiving URSO. And it's a five elements to the score. You plug in, and you can find this score online. You can plug in the age, the bilirubin, the ALK-Phos level, the albumin, and the platelets to obtain a 3, 5 year, and 10-year liver transplant-free survival score for patients with PBC. So how do we treat PBC? Well, the first-line therapy is ursodeoxycholic acid, UDCA. It's given as 13 to 15 milligrams per kilogram per day. About 30 to 40% of patients will have an inadequate response to therapy. The therapeutic effects of UDCA are that it improves bilirubin, ALK-Phos, and GGT. It improves cholesterol levels. It delays histologic progression in disease. It delays the development of esophageal varices. And most importantly, it improves survival free of liver transplantation. So this is still today the first-line therapy for treating patients with PBC. For those who don't respond to URSO or are intolerant to URSO, we may consider a second-line therapy, and that would be obeticholic acid. It's an FXR agonist, a farnesoid X receptor agonist, and the mechanisms of action of obeticholic acid or the FXR receptor is it's involved in bile acid homeostasis, inflammation, and fibrosis. So there are a number of elements involved to the utility of such a drug. So what I'm showing you here is the POISE study. This was a study that was published in NEJM 5 years ago, leading to the FDA approval of the drug obeticholic acid. And they looked at patients who had been on UDCA and had an inadequate response. There were a total of 146 patients in the study. 73 were in placebo arm and 73 in the OCA arm. And the OCA arm were either given 10 milligrams a day, or they were up titrated from 5 milligrams a day to 10 milligrams a day. And the study endpoint was improvement in the ALK phos level to less than 1.67 times the upper limit of normal, and evidence of tolerability. And what you can see here in both the dose titration arm of OCA as well as the 10 milligram arm, there was a significant response, 46, 47% response at improving an alkaline phosphatase level as per the primary endpoint of the study. So obeticholic acid became FDA approved in 2016. 46% achieved the primary endpoint. It's indicated for patients who have an incomplete response to UDCA or who are intolerant to the side effects. There can be side effects with OCA, the main one being pruritus, which could be dose dependent. And that's why we'll often start at the lower dose and titrate up based on their biochemistry and based on their tolerance of the medication. What about PBC and liver transplantation? There's actually, in absolute numbers, there aren't that many patients who undergo liver transplantation for PBC compared to other liver diseases that we do transplant for. However, for those who are transplanted for PBC, they do enjoy excellent outcomes with a 90% one-year patient survival. One could see recurrence of the disease, and that often requires the addition of UDCA in the post-transplant setting to decrease the rate of recurrence. Now, I know this is a busy slide, but I just want to briefly highlight that there are future therapies that are being looked at for PBC, and their targets are shown on the slide. So I'm just going to highlight, for example, B on the slide is improvement in bile flow, increasing hydrophilicity of bile acid, detoxifying bile acids, and decreasing the amount of bile acid circulating to and from the liver. And that is the target of action of both the fibrates as well as ursodeoxycholic acid. For label C, the FXR agonist obeticholic acid, that's where that drug would work in the cycle. And just one other one to touch on is for number D, letter D, that's ustekinumab. It's a monoclonal antibody directed against the P40 subunit of IL-12. This is just giving you some sort of sense of a number of different therapeutic targets that investigators are looking at to come up with new future therapies in both PBC and PSC. And shown on this slide is numerous agents, FXR agonists, PPAR alpha and gamma agonists, etc., which are in phase 2 and phase 3 studies in the PBC space to look for newer agents for this disease. So the last portion of the talk I'm going to just focus on is primary sclerosing cholangitis, or PSC. Again, there are practice guidelines from the ACG as well as the ASLD in managing PSC. So PSC is an idiopathic fibroinflammatory disorder of the bile ducts. As opposed to PBC, there's a male predominance. The prevalence is about 1 in 10,000, but importantly, it's highly associated with inflammatory bowel disease. 60 to 85% of IBD patients, particularly ulcerative colitis, may develop PSC. It frequently progresses to cirrhosis and liver failure. There's a high risk of cholangiocarcinoma as well as colon cancer, particularly in the IBD patient population. And there's really been no improvement in mortality over the past 30 years. And there's also no effective medical therapy for this condition, unfortunately. So how do we diagnose PSC? Well, again, you have to have evidence of chronic cholestasis. One finds multifocal strictures on cholangiogram, either MRCP as shown in the slide or ERCP. One can see multiple strictures, which is classic of a patient with PSC. Liver biopsy is very seldom required. If one does do a liver biopsy, one of the hallmark findings is what's known as onion skinning or periductal fibrosis, as shown by the arrows here, where you can see a significant fibrosis around the bile duct. The role for PSC may be in a patient where you suspect a diagnosis, but the MRI, MRCP looks normal. And in order to diagnose an entity called small duct disease, or an overlap syndrome, potentially with autoimmune hepatitis, there may be a role for a liver biopsy. Now, interestingly, there's no specific autoantibody for PSC like there is for PBC. The one that's most frequently seen is the ANCA, or the anti-neutrophil cytoplasmic antibody, which could be seen in 50 to 80% of patients. There are some other ones that are seen, but not at all specific for the disease. When you diagnose a patient with PSC, you want to rule out secondary causes of sclerosing cholangitis. For example, HIV cholangiopathy would be one. There's another entity called IgG4-associated cholangitis, which may be very responsive to steroid therapy. And so whenever you diagnose a patient with what looks like PSC, you want to check an IgG4 level as part of your initial workup. Now, I did mention that malignancy is a worrisome complication that can occur in PSC patients, and one has to do surveillance for malignancies. One does a colonoscopy at the time of diagnosis of PSC, and if IBD is present, one should undergo annual colonoscopy screening. One also has to perform cross-sectional imaging with CA99 measurements at least annually to rule out early diagnosis of cholangiocarcinoma. So the lifetime risk of cholangiocarcinoma is about 10 to 20% in the PSC population, which is about 400-fold increase compared to the general population. So there are endoscopic treatments for patients with PSC who develop what's called dominant strictures. So if a patient is non-jaundiced and they have diffuse stricturing on MRI, but no dominant stricture, there's likely no role for ERCP. But in those who have a tight stricture and develop jaundice, then there definitely is a role for ERCP, and we'll often do what's called spyglass cholangioscopy, where the endoscopist is able to access the bile duct and directly visualize the bifurcation of the ducts as shown in the endoscopic image of this slide. And they can do directed biopsies as well as brush cytology and test to make an early diagnosis of cholangiocarcinoma. For those who develop dominant strictures, there is a role for stenting. Now, the role of URSO has evolved over the years. Low-dose URSO improves biochemistry, but really has no change in survival. Medium-dose URSO improves biochemistry and has shown a trend to improve survival, but the study was underpowered. High-dose URSO, which had been used several years ago, increases the rates of treatment failure compared to placebo. There's really no role for high-dose URSO. So what are the current ACG recommendations for medical treatment? URSO in doses of greater than 28 milligrams per kilogram per day should not be used for managing PSC, but a lot of practitioners will use sort of intermediate dose URSO, which helps improve liver enzymes, but really has not improved ultimate survival in this disease. As for PBC, there are a number of agents that have been studied, as shown on the slide, none of which are yet sort of FDA approved for the treatment of PSC. I just want to highlight one study very quickly. This is the ESOP study, which was published in 2020, a randomized placebo-controlled phase 2 study of obeticholic acid for PSC. This showed that OCA in 5 to 10 milligrams significantly reduced serum ALK phos levels. And so this is a drug that is being studied further in PSC like it had been for PBC. And there are many other treatments that are in phase 2 and phase 3 trials in this disease as well. So liver transplantation is certainly something we could consider for PSC. The indications are when they have cirrhosis or portal hypertension, if they develop HCC. If they develop a cholangiocarcinoma, there are certain centers around the country that will transplant such patients, examples being Mayo Clinic or Mount Sinai in New York. Many centers, at least as far as I'm aware, all the centers in Philadelphia do not do transplant in cholangiocarcinoma patients. Recurrent bacterial cholangitis or refractory pruritus or other indications for liver transplant in this patient population. And this is certainly one of the main indications for live donor transplant in young individuals with PSC. So just a final summary slide to differentiate PSC from PBC. PSC affects all ages and slight predominance of men. PBC mainly involves middle to older age women, 90% predominance in women. PSC affects bile ducts inside and outside of the liver, whereas PBC only affects the small ducts inside the liver. 80% of PSC patients have IBD. Only a very small proportion of PBC patients may have IBD. The hallmark diagnosis for PSC is the MRI, MRCP, whereas the antimitochondrial antibody is hallmark for PBC. There's really no effective medical therapy for PSC, but there are very effective medical treatments for PBC. And one has to be concerned about colon cancer and cholangiocarcinoma screening in the PSC population. So there's promising landscape for these diseases. There are new therapeutic targets under evaluation. We've spoken about first and second line therapies for PBC. Care should be individualized and risk stratification is important. For PSC, no approved medical therapy. There is somewhat of a role for UDCA, but it doesn't affect the natural history, and it's important to surveil for malignancies in PSC patients. Thank you very much for your attention.
Thank you, Dr. Sass, for that elegant lecture on cholestatic liver disease. I think you've given us a lot of food for thought, and you also underlined in my mind that there are more things that I need to know that I learned through this talk. So thank you. I don't see any other chats or any other questions here. I just want to remind you before we go to our last lecture that we thank Mark Osterberry, Eileen Ryan, and Robert Miyamoto for their tireless effort in helping to make this conference possible and bringing us the excellent video that we've had.